All right. It is 9 o'clock. I'm going to go ahead and call the meeting to order. Thank you all for being here. We are going to test our quorum. Shelley, you want to go ahead and do roll call?
Allison Welch. Barbara
Good morning.
Stolpa.
Sorry. Good morning,
Oh,
Shelley. Sorry, I wasn't expecting to go first. Hi. Present.
Thanks, Allison.
Yeah.
Barbara Stolpa. Candace Williams.
Present.
Terry Lewis.
I'm here.
Christopher Falcone.
Present.
Corey Usher. Dale Woolridge.
Present.
Deborah Verkick.
Present.
Dark Gamer.
Present.
Heather Miller. Josh Gaither. Julie Augenstein.
Present.
Laura Smith.
Present.
Maria Salas.
Present.
Michelle Guadagnola.
Present.
Paul Dabrowski. Zane Kelly. Al Kelly. Ray Croa.
Present.
Anna Clough.
Present.
Sean Bowker. Meryl.
Present.
Tiffany Strieber. And Tom Flanagan.
Present.
Give me a quorum.
All right. Great. Thank you all for being here early in this Thursday morning. First up is the attendance report. In your packet, you all have the attendance report. Please take a moment to look at that. A friendly reminder, if you miss more than 2 consecutive board meetings, Shelley will reach out to you to ask you if you want to continue. Next up, we have a new member, Mr. Chris Falcone, the representative from the Thames region. Chris, welcome to the group.
Oh, thank you, everybody. Pleasure to be here, and I look forward to working with everyone. Thank you.
Excellent. Next up, vacancy report. We have 2 open spots on the committee. First off, a role for law enforcement representative with active involvement in EMS. This has been open for a long, long time. If you know anybody who might fit that role, please let Shelley know. Also, you will see there we have an opening for Injury Prevention Council representative. Again, to apply for those, send a CV and letter of interest to Shelley. Last up on my list is the 2025 meeting schedule. I don't believe it was in the packets, but it is available online. Please do take a look at that and mark all of the upcoming meetings for next year. Oh, look at that on your screen. Ask and you shall receive. With that, I will turn it over to Chief Garcia for the Bureau report.
And sorry, I'll just make one quick point about the schedule for next year. We are also a little bit on our typical cadence. We have historically done the first Thursday for all of our meetings. We did have some big conflicts this time around for 2025. So we have moved those around a little bit. So as you're looking at your schedule, please make sure you print that out and double check the date because it is not the typical third Thursday that we've done in the past. Thank you.
And good morning, everyone. We do have some slides that we will send out to our committee members and participants for today. Thank you very much, Dr. Gaither and Dr. Bradley. So we do have some recognition for our TEPI committee members that are cited within our staff annual report that was published on October 1st this year. We're very proud to share that we are celebrating 30 years of our State Trauma Advisory Board. And just recently in this past September's meeting, the board did vote and approve the annual trauma report, which again acknowledges this committee and all the other leadership that participated in putting that report together. So thank you very much. Please check out our website if you've not seen it already. It's been published online. Our next slide, again, is another recognition to our State Trauma Advisory Board and the fact that our trauma system has grown so much from the last 30 years to present. We are now at, if Kim is on the line, you'll have to make sure I have this number correct. I believe it is now 50 trauma centers, and that the most recent report cites that we had about 49 at the time of the report. If we continue going, one of the things we wanted to remind all of our committees and stakeholders of today is our EMS portal changes that have either started now or will be coming soon. If you have a user account in our Arizona EMS or hospital portal, and that is hosted by Image Trend, we wanted to make sure you know that at this point in time, our EMS agencies can now easily manage their rosters and secure who has access to their data by syncing their EMS portal and Easy Peers Elite account. We do have information available on this slide. If you push the link about syncing up your portal and AZ Peers account, the contact person for that, of course, is Ann Boxspring, who everyone knows and trusts. Next up, due to security changes, we want to make sure that you know that if you have an account with us, email correspondence from that portal is now going to be coming from an email address that will be azphs@arizona.imagetrendlicense.com. We point that out because since it will be coming from a .com email address, we want to make sure that doesn't get stuck in any of your spam filters. So please check that out and make sure that you have that email address flagged as something that is legitimate correspondence from Arizona's EMS or hospital portal. Finally, we are rebranding here at the state. You will notice as we go through today's slides that we have a new color scheme and we have a new Arizona logo that's being pushed slowly throughout the state in the next 3 to 6 months. So as you see our color scheme change on our website and on our EMS portal, please know that that is legitimate. We are moving to a new logo and a new color scheme. You'll see it throughout, again, the slides today. And the next thing that will be coming is our EMCP card. Our certification cards themselves will also get a new look and be rebranded with that logo and that color scheme. So we'll be talking about that shortly and just wanted to give you a heads up in the next 3 to 6 months. If we keep moving through some of our other updates, we wanted to share some job opportunities and recent promotions. We don't have everyone in the room today, but I wanted to start by acknowledging Noreen Atlin. She has been appointed as our Deputy Bureau Chief for EMS and Trauma Systems here at the department, and we're thrilled she has accepted that position after acting in that capacity for the last year. We also have Kim Boehm, who has accepted the role of Section Chief of Trauma and Pre-Hospital Coordination, again, after acting in that capacity. And we are just thrilled. Between the two of them, they have over 60 years of experience in EMS working on the lines, and we're just very grateful that they continue to serve in those roles here at the Department of Health Services and supporting all of our stakeholders. I also have to share that I have started to step into my official role as Deputy Assistant Director. I'm currently working in the capacity of Acting Bureau Chief for you all here at the Department of Health, but we are seeking also a new Bureau Chief for the EMS and trauma system, and that position will be posted on our EZ State Jobs website. We have the link there, azstatejobs.gov. Please check it out, especially if you know anyone who may be interested. We have a number of positions that are listed there that will be posted shortly. It is a position within the Arizona State Retirement System with lots of other benefits, and we look forward to reviewing applicants in the near future. And any questions about that, we can certainly circle back. But thank you guys for allowing us to give some updates on job opportunities and recent promotions. Aside from that, we have a number of other slides, which I will go very quickly on, I promise. And then we will share out these with you all. The biggest update.
Can I interrupt you? One,
Yes, please.
just for a quick clarification, the email update for the change. Can you give us an example of which types of emails go out from that new address?
Yes, any email that is auto-generated from the EMS portal or hospital portal will come from that address. So if you are receiving either a certification card or a registration or license, the correspondence that comes from the system is coming from that email address. So when you get confirmation that you've submitted an application or confirmation that an application has been reviewed or approved, it will come from that email address.
Thank you.
And talking about big news coming soon, Arizona's EMS career pathway is something that we wanted to put on the radar for all of our committees today. We, as of this past month, have received approval from the Governor's Regulatory Review Council, that is GERC, to move forward with our notice of final rulemaking for EMS certification and training here in Arizona. I know that the slide text is very small, but what the recent rulemaking has done is it not only allows us in the state of Arizona to recognize the levels of EMCPs that we've had here for a number of years, but also for paramedics with additional training in critical care. They may now seek a critical care endorsement as part of a new EMS critical care career pathway. That pathway with the new rules will go into effect December 31st. And if we go on to the next slide, you'll see some communications that we have pushed out most recently on scope of practice, as well as our drug tables. Thanks to our Medical Direction Commission and state leadership, we now have an updated scope of practice to align with the new levels of EMCPs here in the state of Arizona. Critical care endorsement will now be able to work under an expanded scope of practice if they have medical direction. And if we go on to the next slide, just reiterating, I know that text is very small, the updates to the drug tables with respect to the new level of EMCP is now available if anybody wants to check that out. Again, it will not go into effect officially until December 31st. And I'm going to pause there just for a moment to see if Dr. Bradley or any of our other docs from the Medical Direction Commission want to add on there if I missed anything.
No, I just said that. I think thank you again to our committee members, both PMD and MDC for helping to get this put together. This is a big list that was really on over 6+ months. But I think the finished product is a huge benefit to the entire state. So again, a big thank you to everyone. The one thing I'm trying to get messaging out is as hospitals use hospital-based paramedics, just to make sure that you are reviewing these drug tables. There are quite a few additions of new medications, especially oral medications, which have been enacted from the hospital system. However, some of the more advanced medications that are more appropriate for critical care endorsed paramedics are now only going to be allowed for critical care endorsed paramedics. So there is going to be a little bit of change. So make sure if you are a hospital that utilizes paramedics that you review the upcoming list and changes to ensure that you are compliant with that.
Thank you, Dr. Bradley. I'm sure we'll do one more push to continue to socialize the scope of practice and drug tables in advance of January. If your agencies or medical directors have any questions, please reach out so we can continue to socialize that. And then again, it will go into effect officially December 31. As of January 1st, we will have the applications online for any of our paramedics that are seeking that critical care endorsement as of January 1. And just going through a couple more updates if there's still time. We do have in our slides for today updates on recent bills that have passed, although I won't go over this slide in detail. We can keep going to the next one. And rulemaking updates. Please note that under pending rulemaking, I know you've seen this slide before, EMR and critical care scope of practice has been approved by GERC. It will not be filed to go into effect until December 31. Similarly, EMCT certification and training again has been approved. It will not be filed until going into effect December 31. We are still waiting on interfacility transport reporting requirements to go into effect. Those are scheduled to go into effect as of January 1st, and we will keep you updated on any additional meetings and approval. Moving forward, there are, again, links to all of our rulemaking information if you would like to look at those items that are scheduled to go into effect. And beyond that, Shelley, I know we have quite a few other slides on TON rule updates just for review. If you can advance a couple more slides. Wanted to talk for just a moment about rural education funding results. I think we'll spend more time on this during our education committee later today. But I want to thank very much our regional councils that have participated in the program and the overall impacts that I'll just spend a second talking about with this group is that in the last couple of years, we've been able to work collaboratively with our 4 regional councils in the north, central, southern, and western part of the state. And overall, we have been able to successfully educate over 250 participants in that program, which has ended up resulting in 120 certified rural paramedics across the state of Arizona. It's really remarkable when you look at the number of EMCPs by county, that we have quite a disparity from north to south. The number of paramedics across our state, of course, is much lower than the number of EMCPs that are represented here in the map that you see. But we're very pleased about that partnership with each region and the results of that rural paramedic program, and look forward to talking about that more at our education committee meeting. I am going to turn it over next to Julia's team that has some other updates on the Bureau report. Julia, I know your slides are scattered throughout today's packet. So please let us know where you'd like to start.
The last one, buffet.
Yeah, so sorry. So on the naloxone leave behind program, it's continuing. Our numbers up till Monday of this week, we have 3,200 of those EMCP experienced. We've shipped about 3,000 kits out. Our agency numbers up to 47, which is awesome. And we have about 400 kits that are scanned in out there. So if you are interested for your EMS agency, give me a call or hit me up on email, or there's a link there. And we're excited to have you participate.
I had a question from one of our agencies on this. If they have civilian employees, like community assistance program folks that want to give these out as well, are there any limitations related to the funding that would keep them from handing them out as well, or do they have to be handed out by EMCP?
I ship the kits to an EMS agency.
Great, thank you.
All right, is Carissa on for the trauma vendor update?
Good morning. Yes, I'm here.
Oh, there's slide.
Second to last slide, shall we?
Sticker work.
Yeah, sounds good.
Almost. There we are. Okay. So we are still working on completing the RFP process for the trauma registry. We will let you guys know as soon as that is done. We're working with the procurement department. And then as we've been discussing, Trauma One is being sunsetted out January 1st, 2025. So we've been working with the hospitals to get them transitioned over to the ESO registry. We have meetings every week that are Q&A sessions to go over training. Hopefully all of you know what I'm talking about. We've had quite a few meetings, but if any of you have questions, feel free to reach out. And I think a good clarifying point is all 2024 records will still be entered into Trauma One. And then starting January 1st, 2025, if you're a web-based user, Trauma One won't support the 2025 records. So you'll need to use the ESO registry for that. So I think there was a little bit of confusion. So I want to make sure everyone understood that. I don't have any other updates right now. We're just working on the training and getting everyone access to the registry. If you have any questions, please feel free to reach out. I recommend attending the trainings and the Q&A sessions. The full data set for those of you who submit a full data set, level 1s, 3s, and some of you 4s, is on Tuesdays, and then reduced data set is on Wednesdays. So does anyone have any questions for me right now? Okay.
Chris, this is Rachel, I don't have a question, just a comment. We just wanted to thank you for all of your hard work on this ESO transition in parallel with the RFP. And especially your work with the rural critical access hospitals that are level 4 trauma centers in our state. I know that you've done significant outreach and specific targeted sessions for those critical access hospitals that are level 4 trauma centers. And thank you for your support, because we of course want to make sure it is a seamless transition, as you said, from the current system to the ESO patient registry. You've just been such a great leader in this process. So thank you, Chris.
Thanks. Yeah, no problem. I'm really grateful to work with such a great group of people. It's obviously never fun to move systems, but I think we'll get through it, and we'll be happy this time next year, right? It'll all be great. So feel free to reach out with any questions.
All right, and then really quickly, I can give an update on the strategic plan. So as you are probably all aware, we've been working on drafting that for the last year, and even before that, working on the needs assessment. So that was presented at the September EMS Council meeting and approved. The next step was for that to go over to the governor's office. And so it has been sent to the governor's office, I believe, and we're planning to start kind of working on some of the implementation starting in January. So thank you all for your work on that. And then just really quickly, I will also mention that this week is Crash Responder Safety Week. So thank you all for your work as first responders and EMS trauma providers to keep safe on our roadways.
All right. Thank you. Anything else from the Bureau? All right. Moving on then, let's hit our updates from our groups. First off, Trauma Registry User Group. Maria? Anyone else from Trauma Registry?
Can you hear me?
Oh, there you are. Yep.
I'm sorry. The updates from the truck meeting, last meeting, we went over our NTDB changes for 2025. Also our next submission is January 2nd, 2025. We also went through the review of physical abuse fields for the ACS guidelines on capturing those abuse codes. And the other thing, like Carissa said, we're just having those meetings every Tuesday for full set facilities at noon, and then Wednesdays for the limited. And we're just busy watching all the videos for the new registry. That's all on my part.
Okay. Thank you very much, Maria.
Thank you.
Next up, Trauma Program Manager Workshop. Heather.
Hi, Josh, can you hear me? Oops, sorry,
Yes,
Krista,
yeah.
go ahead.
All right, can I just chime in real quick? Thank you, Maria. I wanted to just make sure everyone knows the meetings are at 1 now with the time change. They were at noon, but with the time change, they're at 1. So that's just wanted to make sure no one shows up at noon. Thank you, Maria.
Oh yeah, I'm sorry.
Perfect. Thank you
Thank
for the
you.
reminder.
Yeah,
All
so
right.
for the Arizona Trauma Program Managers Workshop, we met last on October 11th in Banner Payson. It was a good meeting. We had our state updates. The PCH showed off their SIM ambulance. They did some pediatric readiness projects, went over some of the registry transition, and we reviewed some clinical practice guidelines, developments, and implementation, as well as talking about some PI. So overall, it was a good meeting, and we've already started planning for the new year and getting dates and locations for next year.
All right. Thank you for the update. Next up, EMS Registry User Group. Ray.
Good morning, everybody. As of right now, the only update I have is short and sweet is the meeting that was scheduled for the 14th of November has been moved to January 9th. I believe it's on the website, and I'll be moving over, sending out the invites for that. The only other thing I have is I know Anna sent out the new 3.5 facilities list for EPCRs, so make sure you're up to that. That's all I have.
All right. Thank you, Ray. Next, we'll move on to discussion and action items. First one is simple. Let's take a moment to review, discuss, amend, and approve the minutes from our last meeting, which was July 18th. I'm happy to entertain a motion to review to approve that.
Motion to approve.
Thank you, Michelle.
I second.
Thank you, Allison. With that, any discussion or requests for changes? All right. Hearing not a lot of discussion and knowing that we all have busy lives, I'll call for a vote. All those in favor of approving as presented, please say aye.
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 All those opposed, please say nay. Any who wish to abstain, please say aye. All right, hearing no abstentions or no votes, we'll consider the meeting minutes approved as written. Next item, discussion on TEPI's share user group. Dr. Bradley, do you want to do this one or?
Do we have anything to present as a review?
Nothing in specific, other than just highlight that user group. We discussed, what kind of metrics should be tracked, and we reflect back to Epstein, variables as well as, goals should be what define what we are, looking to track using that. This is with reference to, the cardiac registry. We discussed what kind of information should be being collected and a little bit more alignment towards cares. Not necessarily taking cares on, but aligning with them so we can be comparative and relative to them. I think those are some of the high points. Was there any other discussion from the shared text?
I think a lot of the conversations that we're trying to have is to simplify the data set a little bit. When the initial data set was created, that's really close to 20 years ago now. At that point, many EMS agencies brought paper records bill for documentation. And as technology has evolved, often the standards of care have evolved both at the pre-hospital level as well as kind of the hospital level regarding clinical care. We're looking to simplify some of those data sets. So one of the things that we want to do is have the pre-hospital data fields aligned with CARES. The reason for that is that CARES is census 3.5 compliant. So any EMS vendor is going to be that 3.5 compliant will now have the correct data variables for that. So again, looking to make that pretty simple. And then a reminder that EMS Council approved that starting in January to be a premier EMS agency, you would have to have some data quality metrics specific to our out-of-hospital cardiac resuscitation. So again, try to improve the quality of data that we are collecting electronically. The importance of that is in a task that was kind of staffing and personnel to support combing through narrative. We have over 1 million records a year into our ADHS registry. And so there's frankly just not the ability any longer for people to go through narratives to actually capture this. But we do realize that with the field, all the data that we actually need are in those kind of queryable fields. And that is why we're looking to do that. The next component we're looking to transition is going to be our CEDAR database, which is the hospital data entered in, and really looking to simplify that significantly. That is a pretty heavy lift right now for the hospital. Adam gets lots of questions from hospitals of how do I answer those questions? If they answer one question, it opens up a bunch more, which then opens up another layer of questions. And we are really looking to make that very simple and align with the CARES hospital data sets. I think that summarizes that. Amber or John, if there's anything that you are that we need to ask.
Good. All right, thank you for the update. Next up, item C, discuss pedestrian data opportunity. Julia?
Yeah. This is really an outcome of a work group that we've had recently as part of this grant that we received from the governor's office of highway safety. So the task of that work group has been basically to work collaboratively with ADOT for the highway safety data and identify opportunities for injury prevention. So over the last year or so, we've been really identifying pedestrian safety as the topic for the work group. So we've done a couple of things in terms of working on a blog for pedestrian safety month and hope to develop toolkits in the future, and just kind of wanted to see if pedestrian safety is a topic of discussion that the group TEPI would be interested in pursuing or working on any kind of projects with us as the work group. And then I know also the EMS for Children program has been working on some similar kind of projects. So we just kind of wanted to open that up to the group to see if that was a topic that any that we wanted to kind of work collaboratively on, and
Can you maybe give us a little more color or maybe example of what you envision? When I think of injury prevention, pedestrian safety, I commonly think of sidewalk markings. I assume that's not where you're going or something different.
yeah, most of the projects that we've talked about have been kind of more related to post-crash care and kind of making sure that EMS is equipped to, interact with patients. And then also if there's any kind of preparation or training or educational materials we can provide to like bystanders as they happen upon some kind of scene. So look, that's kind of the topics that we've been discussing. Margaret, if you've got anything to that?
Yeah, so for the EMS for children side of things, we're seeing the highest incidence of injury is around 10 to 15. But we've developed some pediatric crossword puzzles to educate the younger population. But we're looking at proposing, working with stakeholders on doing some high school skits to educate the older population and educating them about the pedestrian safety, especially at crosswalks, because that's the highest data point right now. So,
Question, would some potential funding be dispatch aided instruction for the public for that fall under this, would you think, in terms of the dispatch being able to get training on how to provide education to the layperson if they apply or came across one?
Yeah, I think that would definitely fall into the scope of the grant and what we're trying to accomplish. Yeah, I don't know if this grant would help, but yeah, definitely more.
Okay.
Discussion from committee members on the topic. Maybe to stimulate some discussion, I think some of this focusing on post-crash care and to build on what Dr. Bradley mentioned, really getting the right resource to the right incident could be an area for improvement. These obviously pedestrian strokes are very significant mechanism of injury, so ensuring dispatchers, one, can give instructions, two, we have resources to get the right resource. What does the dispatch question look like to do that? Which with our world partners could be helpful. And then certainly looking at data on post-crash care could be very interesting. Looking at, of course, what we do on the EMS side, PXA administration, IT fluid administration, those data points could be interesting.
Really on here, this is just for discussion, so of course we can always discuss later. And if anybody's interested or has any ideas on projects they might want to work on, then feel free to reach out to.
Anyone else in the committee comment questions regarding pedestrian injuries? Okay, hearing none, we'll move to discussion item B, data dashboard request. Add the number of EMS agencies who report to AZ peers to the dashboard.
This was a question that had come up at the last meeting. I think we wanted to clarify. We didn't have a note as to who asked that. So there's a pretty consistent EMS agencies that do report data to AZ peers, but that's something where it can be slightly fluid. We have some smaller agencies that tend to go a few months without reporting any data. They simply don't call. Does that mean that they're no longer reporting? We wouldn't necessarily know that. And so I guess the question, not what you would ask us at the last meeting, are we simply looking to say on an annual basis that we update that? So if we do have an annual update to our dashboard that we say, okay, as of 2024, this is the number of agencies reporting data to AZ peers. I wanted to get thoughts from the group if that's a reasonable way of essentially answering that question, which is just on an annual basis versus more frequently.
Great question. I'll give you my personal opinion and then feel free to ignore it completely. I don't think that's meaningful data unless you also have the number of EMS agencies and you can report the percent of the agencies reporting. If you put up there a number of 100, does that mean that it's 50% or 99%? So I would only support it on an annual basis. I don't think it has any more utility. There is some benefit to knowing that this data reflects 50% of Arizona or 80%.
And I think we have a pretty good idea on that. I will say that there are still many very small agencies that we have a list of, obviously all the CON agencies, and we know the big ones, but there's definitely EMS agencies. When we try to come up with a singular list, it is a little bit of a challenge. But I think we can say, realistically, I'm not sure if Ann or Ross will speak to it, but I think what percent of our agencies is a very high number. But we can definitely look at that.
It may be simpler just to say those agencies with the CON that are reporting. That essentially is the ones we really care about.
I see Ann, your hands up.
Yeah, I just wanted to comment. So I think, and I don't know exactly how we would do this, but I think really the question you're asking is what percent of the population in general is going to be covered by this? Because we probably, if you look at each agency, for example, and I'm not picking on them, I just happen to know that Patagonia Fire is not reporting, but they're volunteer and, I don't know how many runs they ever have. So you could have a large percent of agencies you look at and you go, oh, only 50% are reporting. But you probably still have almost the entire population of Arizona covered in one way or another. So is that really representative of what you're looking for? It makes it look a lot different than what we're really getting. It is really hard with non-licensed agencies in Arizona. We only license the ones that transport, and even then, not all transporting agencies have to be licensed. And we could put that up there. We certainly find the data from non-licensed agencies just as important, especially for things like cardiac arrest. But it is at least a consistent denominator that we could use. So we have different ways we could look at it. We could do it more frequently, could do it quarterly, or even maybe, I usually use 45 days, which isn't anything scientific. It's just kind of when I see that usually very small agencies that report at least have one run. We also have air agencies that are licensed, and we do like to include those since they're licensed, but DPS isn't licensed because they don't have to be, even though they transport. So it's a bit squishy, and it kind of depends, I think, on what are you trying to know when you see this number? What are you trying to have it communicate to you? And then we can figure out kind of what that is.
Yeah, I certainly don't want to be the only ones contributing, but I'll again give my 2 cents. I think it helps to know which portion of the population that covers. And I agree with what you said, Ann, the denominator needs to be consistent. So using those CON holders may be a nice consistent one. And knowing that we still care about Patagonia Fire, don't get me wrong. They're very important. They provide a critical service to that community, but they don't transport. And their data wouldn't be reflected in this particular number. It would still be obviously included, but not in this number. Any other thoughts from committee members? Okay, all right. We will turn that back over to the DHS then for you guys to mull over.
Okay.
Next up, discuss the heat-related surveillance dashboard. Look at that one.
I think the goal of this was just to share this dashboard as we have seen the number of heat-related illnesses increase in the last couple of years. This is, I believe, the first year that ADHS has hosted the heat-related dashboard. And this has been a big push nationally as well as within Arizona. So I wanted to highlight that work and just kind of, really, as we are in now a cooler month, kind of start hopefully preparing for next summer and what we can do to decrease the number of heat-related illnesses and injuries. So I just wanted to make everyone aware that this dashboard is live and that it is something that we utilize to please do some prevention work moving forward.
Thank you. And this dashboard is available on the Bureau of EMS and Trauma website with the others?
No, this is an ADHS. So we can, I think it is actually linked in the agenda. So we should be able to take a look at that in the agenda.
All right, thank you. Any questions for the ADHS on their heat surveillance dashboard? Okay, next up, drowning data. Looks like Ann and Dr. Brad.
So I will kick this off and then Ann, if you want to kind of help if I speak on any of this. So in the past, for many years, the Bureau of EMS and ADHS collected drowning data from EMS agencies, and that was done on an actual paper form that was faxed into the department, and that was collected by Dr. Flood, who was here at the department for many, many decades. Over time, what we have found is, number one, EMS has gone to electronic charting, but many of the questions that were asked on that drowning report are not part of a standard questionnaires that you would ask on the EPCR. So things like what was the water temperature, different things along those lines. Were there any barriers in place to look at drowning? So the past summer, we had a pretty high number of water-related incidents, unfortunately, throughout the state. And so there were a lot of requests that we got from the media, from different EMS agencies of what can we do to collect better data. And we wanted to bring us back to this committee to talk about kind of why we aren't doing what we used to do, which is number one, I don't think EMS agencies have the ability any longer to kind of, give their crews the paper form to kind of collect these data elements, and then who's going to fax them in, and then who here at the department is collecting faxes and kind of collates that data. But is there something that we can do to kind of focus on drowning and submersion incidents within our data set? Do we want to look, I think Anna said we can build custom elements for agencies that wanted to do that. But again, that agency would have to work with their vendor to then say, we want these custom data elements. So just say EMS and TEPI said, yes, Arizona, we think it's important. We want to make those fields a custom data element. This committee can move that forward, but it would not be part of your routine NEMS 3.5 data set. It would need to be a custom data set that your vendor would have to create for you, which often does have a cost for the EMS agency. So we like to kind of paint that picture because we really want to support this work. We recognize that this is a big issue in Arizona, and we have seen, unfortunately, increasing numbers of drownings. But how do we maybe look at some of this, and what else can we do with the current data as we do collect this? So that's a little bit of the background. I know we had a lot of questions from EMS agencies wanting to figure out, can we form a work group? Is there something else we can do to address?
And Dr. Bradley, if I can add on before Ann jumps in here. Since Dr. Flood has retired, we have received outreach from the community with respect to how we're capturing this data and any annual reports that we provide on this data. In preparation for legislative session, we've also received some questions at the department from lawmakers that are very interested in this subject and getting as much information as they can to help improve safety around water. And so anything we can do in this area, we know that we have a lot of champions at the state that are interested in not just data, but also resources. Thank you.
I think Ann first, and then we'll go to Dr. Rice.
Sorry, did you mean me, Ann? Or just?
Yes, yeah, sorry.
Okay. No, that's okay. I just want to make sure there actually are a lot of Anns sometimes. So I agree with both what Gail and Rachel said. I think we have a lot of possible solutions. None of them honestly are perfect. Part of it is going to be, if you want to do custom elements, we're going to need to come up with a list that people can agree upon. If we're going to go down that route of trying to do the effort of permanent custom elements, what's needed, what's really going to be looked at, what's important. As far as I know, there's not a national standard. We certainly have some of these data elements that were collected on that previous worksheet. It's not that easy because can't take a paper worksheet, but then it still comes back to, you can send a PDF, but what are we going to do with that when we get it? It's not really easily analyzed. We'd have to find it. Who are we going to give it to? There's not really somebody that's doing that. And if you make your own little questions in your system, those aren't going to come across to us unless we create those custom elements. So it's kind of going down what is really important for everybody and what path do we go down to figure out what's most important for the community. So.
Thank you, Ann. Dr. Rice.
I was gonna say something similar to Ann, in that it seems like the work to put on agencies to get sort of spotty data across the state doesn't seem like it might be worth the effort. I wonder if this would be better data to get from like Dave and the HDD and like hospital data versus like, why do we specifically need EMS data on submersion and drowning injuries? Because it seems like it's probably not super accurate data anyways. We won't get a lot of it, and it seems like it might be more reliably captured from other sources maybe.
I think in the past, the data that we had for EMS was actually really good because it was pre-responding to the call that had, you know, here's the pool barrier, lack of pool barrier, this is the water, what was the water quality, what was the temperature, all these other elements that were in there was pretty good data. Once you get to the hospital, you start kind of playing the telephone game that gets slaughtered down. So data will only get into Dave if it is obviously a fatality.
Right.
If you have someone that is the hospital discharge database, I mean, that is something, but again, that is very dependent on what code gets assigned at the time of discharge. So if it's not listed as submersion, you may not then actually capture that data. So those are a little bit of a barrier.
I just think it's hard to get that type of EMS data like we talked about. It custom data fields are not something each of our agencies are going to want to implement.
Dr. Woolrich.
Hi, yeah, thank you for letting me speak on this. I look at this from the perspective of the child fatality review and being familiar with the child fatality review. We have very robust data on the drowning deaths. And in those reviews, it's multiple agencies reporting. There's statute that protect the collating of that data. We have invaluable EMS run data, also law enforcement interviews and reports. But you have a program that's statewide with a dedicated coordinator that's literally hand combing through those data records. So I echo what Dr. Rice had mentioned. And what Gail had said earlier too was that this is be extremely valuable as far as contributing factors and preventability. But getting all the data and getting clean data in a thorough manner, I see that happening in child fatality review, but it has those resources that allow it to do that. But I support the value, but I do see the barriers, and I think the child fatality might be a model to look at their approach because they do have a robust data set on the deaths. The non-fatal drownings, I think that's the real higher volume number and the number that would be more valuable to add to that injury prevention search. That's my 2 cents.
Thanks, Dr. Woolrich. Other comments?
And I think I'll just so that part of what we wanted to do is really to talk about with the committee some of the challenges, because I think we had a lot of EMS agencies saying, hey, we want to be able to send the data like we used to, but not realizing how it actually used to be collected and why that's not really a realistic option any longer. So to at least talk about why things like custom elements are really challenging because of the cost associated, and then it's not really a standpoint out. We're not aware of any national standard for this, so you're actually kind of creating something without like a set national data set that is custom. There's a lot of cost variables that come into play with that.
Thank you. Anyone else before we move on? All right. Thank you all for the comments. Last item on our agenda to discuss the heart safe requirement, attachment 6. For those of you in the room, if you have packets, take a look at those. Adam?
So we just made a small change to the Heart Safe program. This is a program that takes our AED program one step further, and it asks for locations and mapping, and it asks for some drills and things like that. So entities like cities and religious communities and any other type of community has the opportunity to participate in this. But what we found was that there was a bit of a barrier in the up in the top of the requirements. I did do it in red. So what I was finding is like I got a number of inquiries that ended up they said, well, you know, why we have to do this first, do 6 months of document submission first. And I said, okay. And so we had to look at it and we revised it to make that a little bit more low barrier. We'd like them to get into the program as soon as we can and then just provide documentation from there on. So we thought with that change that we could have captured those. I've since recontacted them. We could have captured those willing program participants and actually get them going in the program rather than to be retrospective, collect a bunch of stuff in a probationary period, I guess, and then tell them that they're good after 6 months. So we thought we would just kind of ask for their documentation, and we left it somewhat purposely brief. Copies of AED maintenance records, that was motivated by some of the inquiries saying, you know, my AED maintenance requirements conflict with your required, so we left it a little bit vague, so we can kind of blend those two together. And so hopefully that makes it a little bit more low barrier as this is the program we'd like to expand, given the strategic plan. Do anybody have any questions on this? That's the only edit that there was on this one. It's the same edit across the rest of the Heart Safe Recognition Program document. I think it shows to you if you'd like, but that was the only change we made. Is there any questions about the Heart Safe program?
I had a question about the general heart space. How many people actually have the designation?
I think we have a few dozen, let's say, I don't know, what you think, 30 something total between cities and.
I'd seen it for. I'd seen
No, I'm not a big deal. I'm just curious.
when it first started, obviously many years ago, I think we had a lot more, but people have kind of phased out, so we really have to do some work to get people re-engaged. We definitely have several features, like a beach handler, MG, but yeah, it's sort of the currently recognized, so I don't know.
I could follow up with that number.
No, not a problem at all. I think I was only asking because I think this is a very important program. Obviously, access to AEDs is critical for improving survival. I think it's something that at least I would support strongly. I think this is a good simplification. And I would certainly favor additional simplifications as part of our overall share program review to make this even easier and engage further participants. It could be very positive. Other questions or comments from the committee? I believe, is this an action item or this was for information?
It was just
Preparation. Other questions, comments? Stacy? Is participant. All right, thank you, Ed. I'm going to next turn it over. Oh, I'm sorry. The call for agenda items for next meetings. Please send any agenda items to Shelley, and she will coordinate our agenda. Last but not least, call for the public. Anyone else want to contribute? All right. Upcoming events, you can see in front of you there a nice list of winter activities. And with that, I will adjourn the meeting with a note that our next meeting is March 20th. I will see you all then. Thank you all.
Thank you.
Thank you.
Thank you, everybody.
Thank you.
Mm-hmm.